scars. Till now, we cannot find a specific treatment. In this session, last session, I talked about combination sum disease. The role of scar here is the combination. There's no device in the whole world, an energy-based device or any injection can be standalone, except fractional. So first of all, my colleague talked about this slide in the early morning about the difference of aging, about the thickness. Here we have to be specific which layer are we trying to treat. We are trying to treat the dermal layer, so where we stimulate fibroblast, new collagenesis. But actually in old skin there is atrophy of skin, we have effacement in the pathology, and there is a hyperkeratosis more than the young age. So please, if you find, you have to make good assessment for your patients. If you find this situation, you have to prepare your patient well with retinoids, moisturization, until this hyperkeratosis be less, so you have to, then you can start your treatment. Okay, we have talked before, alhamdulillah, two presentations are back-to-back about the effects and how the microthermal zone will cause skin rejuvenation. We have seen this slide before, and we have seen this slide before. So let's jump to acne scarring. So not all acne scars improve as much as they all improve. We have first rolling scar. In rolling scar, the rule of combination here is to do subcision with your fractional laser, because there's a fiber anchors downwards which pull your lesion downwards, so whenever you do fractional laser you will not get the results you want. So if you want to get a best result of this, you have to do subcision. And then the box scars, the ice pick scars, and the hypertrophic scar. And this is our guide to treating scar, whether it's erythematous or going through the vascular lasers, PDL or long pulsed KTP. And then for every scar, the reliable is to do combination. So when you have the ice pick scar, you can combine with topical TCA, but you have to be very cautious. Unless, if you are not confident, do the cross TCA technique you all know. And when you have boxer scars, you need to fill down the scar. So it's better to do filler injection or fat injection and do fractional laser to improve the texture. And the rolling scar, as we have talked, we will need to do subcision and sometimes inject fillers or fat to improve the outcome. Here, we want to talk about the edges of the scar, and sometimes there is a raised lesion near to the rolling scar and near the box scars. So when you reach the depths, you will, when you reach improvement, you will feel like it's always depressed. That's why you have with a surgical hand to ablate those elevations to make a smooth surface. Here, about this case. This case is a mixed type of scar. We have fine boxer scars, rolling scar, and ice pick scars. So, what's your recommendation for this case? We have to combine all methods we know, but this patient was only treated with fractional laser. And as we see, all scars improved much better, except the boxer scars that we need to be injected. So this patient was refusing injection, and she was satisfied with this result, but this is a practical method. It's a live case that you will see that not all scars will be improved as much as each other. You have to do this filler or injection so you can achieve the better result. This is the other way. You will see most of the rolling scars is improving unless Bardus tail boxer scars. So, this case, what do you think? We have boxer scars. We have rolling ice pick scars. So here we do a different combination. This patient was agreeing to do whatever I want. So first of all, I used like 3 to 4 sessions with the fractional laser and combination with a biostimulator. So we inject 3-session fractional laser followed by single injection of diluted calcium filler, and we have seen much improvement regarding the most hard type of scars to treat with fractional laser alone. So this scar, what do you see? Any recommendation? ماشي. So we'll see also يعني mixed type of scars, rolling, and some ice pick scars. So this patient, here is your assessment. You know what to combine and when to combine. So this patient was traveling and not willing to stay a lot, so he needed a quick treatment. So if I do a single fractional laser and he go back to his country, he will not be satisfied. So we have to go for injection here. Started first with fractional laser for improving in skin texture. As you know, the collagen will stimulate it along 6 months, so he will continue with improving. And a single session of fat injection in 2 layers. We injected deep to elevate the lesion and make a smooth contour, and a nano fat, an SVF, for improving the skin texture itself. So the combination of these 3 treatments will improve the patient. Okay, traumatic scar. What do you recommend intervention with a fresh traumatic scar, whether يعني fresh scar or a surgical scar or traumatic scar? 4 to 6 months is the ideal to start. In this case, I started early. Remember that always start as early as you can because you will get the best outcome. And this scar, what I was talking about combination. This patient improved regarding the texture very well. But what about the volume loss? This patient will not feel that he is treated well unless there is a volume correction regarding this scar. So we'll see contouring from the superficial and the volume elevation from beneath. Keloids, very debatable. Using fractional laser with keloids, you have 2 options. Either remodeling of collagen and transepidermal drug delivery of your corticosteroids or 5-fluorouracil. But to what lesion? The penetration is limited of fractional laser. As much as you increase the depth, it's limited penetration. So when you have a little bit elevated lesion, please, you can do your fractional laser as a transepidermal drug delivery and put your topical corticosteroid, triamcinolone, 5-FU, whatever you're using, and you will get results. But if you have some elevated lesions a little bit, whatever you put topical under occlusion, you will not get the best results. So I recommend in elevated lesions to inject corticosteroids or 5-FU and do fractional laser, but not rely on the transepidermal drug delivery when you have so elevated lesion. And this is the idea of transepidermal drug delivery through the microthermal zones. And in papers, they see that it make a sustained release, so it will be better. And again, if you are doing a transepidermal drug delivery, you remember the use of the 120 micrometer. Okay, how can you treat this case? Steroid injection, fractional laser, combination of both. Drug delivery, inject. Combination injection. Okay. Okay. Combination. Okay. So in this case, we do a surgical handpiece removal of the keloid, and we are doing very frequently in Egypt right now. It's a localized lesion. You can use it, but in the ear, especially, you have to be very, very, very cautious. Your assistant must be prepared with ice, so it can make this area cooler. Because using a cartilaginous area like this with too much heat, you will have a cauliflower ear. You don't want this disfigurement. It will be worse than the keloid the patient has. So you have to start, to work intermittently sometimes, and your patient put ice, start work again till you reach the base, you cautery the base, and then the patient will heal. This photo is after 3 weeks. All of you are asking about the long-term follow-up. How long this patient will stay out of her keloid? What's about the recurrence? The recurrence if keloid is present, but this patient was followed after 2 years, and there is nothing. So I recommend, if you have a small keloidal lesion in ear after piercing, to start working smartly with the laser, fractional laser, the surgical handpiece. Here, try to be smart by doing it not continuous mode on a very high power. You reach the crumbling I'm talking about. And my first aim was to maintain this contour of the ear, not to shrink. So take as much time as you want to reach a better result. Acne keloidalis. What do you recommend? Injection. We all inject in the university. This is our rule, is to inject corticosteroids. It improves much better, especially when the keloidal lesions are connected. But having focal keloidal lesions like this will make us to think about treating it with the previous way. So this is after 2 sessions. Remain some here, keloidal lesion will be arranged for the 3rd session, but the patient is so much satisfied. But this patient, as the psoriatic patient I told you about, you have to take care of his main treatment, stay with whatever isotretinoin about the activity, so you cannot recur back frequently. This is another case of keloid, but this is only 1 week after Yani. The patient didn't come back, so I hope she's well, Yani. Okay, complication. As any energy-based device, you have the infection due to the disruption of the skin barrier. You have to use wise moisturizers with ceramides and probiotics and prebiotics, and there's much now in the market. Comminerization, it can be eliminated by good history taking. If this patient, you are talking with your patient, you know he is psoriatic patient, he's a vitiligionous patient with activity, please postpone your session, you must experience comminerization. Or even take care sometimes when you rejuvenate patient, there is a lot of plain warts in the field. So please be cautious because it will be a very hard case to treat afterwards. This chromia is treated with feathering. I told you before the random mode about all lesions, so they do not feel the demarcation line. Prolonged erythema can be treated by arnica, IPL, or vascular laser. Acne and media, actually, sometimes it because the occlusive effect of the creams you are using, so don't use too much heavy creams on these patients. Inflammation is needed, but too much, because it's based on the inflammation. So I do not use corticosteroids to any of my fractional laser patients. I just prescribe healing moisturizer. But if there is too much inflammation and crustation, please start with corticosteroid to eliminate the incidence of PIH. And thank you. Any questions?
Thank you, Dr. Marwan. I don't know if someone has a question for Dr. Marwan. So I'm gonna ask a question about this keloid that you treat with surgery. How you do this? It's just about cold. When you put ice, it doesn't come back, or it's about
you put ice first to make the area cool, and you preserve the cartilage from the too excess heat because it will crumble. So you put ice, may beneath the keloidal lesion from the other side, and start working for, say, 30 seconds to 1 minute, and stop. Ice for less than 30 seconds also, and then start to work again until you reach the base, or may you make it on 2 sessions. But this is the safest way to eliminate the keloid and preserve the complication that your patient may experience. Yeah.
Okay, and you don't put any cortisone or presotherapy? Nothing?
Not a single application.
Okay, and you have many patients that you do with this?
Yes.
Okay.
Yes.
Thank you.
Yes,
Thank you.
My advice is always start to be cautious, يعني, but other than that, it's a perfect method. Yeah.
Okay, thank you a lot.
Yeah.
Thank you.
Pre-laser protocol and after laser protocol?
Unless the patient is well, there is no inflammation or infection in the keloids, I start working immediately. يعني. Well, post-care, the normal post-care of any ablative fraction laser, prescribe antibiotic topical and healing cream, and that's it.
I'm talking about, like, we know that there is a lot of recurrence of keloids, especially person keloids, after surgery, after laser, and like, do you use silicone ointment or silicone
For
sheet
sure,
after?
for sure. The patient is go for the fractional laser session with combination, or if it's erythematous, first do pulsed dye laser, and then until the erythema is fading, you can start fractional laser. You work for 1 week with the healing creams, and then 3 weeks with your silicone application, and then the patient return and continue this cycle. But combination is a must with all what you can do. Silicone use at home, and at the clinic you do the 2 ways of mesotherapy for keloids. Compression? عشان bleeding يعني ولا no no لا no no need. I understood compression for لا no this case as you saw it there is no any indication. You can try it with the small one first and you will see the result and then you'll be confident يعني. Thank you.
Thank you. My question is about stretch marks. The red ones. Do you use the CO2 laser or any combined treatment with, such as the NDI?
Actually, I do a combination of NDAG microsecond.
Which one in the first time?
The microsecond NDAG first.
Yeah.
خلاص, and then I use fractional laser. Don't do too much parameters on the stretch marks. You will see a lot of PIH in this treatment. Please, you're just making a light rejuvenation. It's already a very thin and scarring skin. So do not use much aggressive treatment. Just on a very low watt and a pulse duration 400 to 600 microseconds, and combine it with the microsecond NDAG laser. You will feel very good results.
And the same question for the fresh scars.
For fresh scars, you can inject Botox first and then continue with using fractional laser. As I said, from 4 to 6 weeks after suture removal, you will achieve the best results you will see.
No NDAG with the first time.
Not NDAG. You can use pulsed dye if it's erythematous. Yeah. Thank you.
Okay. There is another question. No, it's okay. Thank you.
Thank you very much, Dr. Marwan. It was a very good presentation. You can applaud. Donc voilà, ainsi s'achève la session Edge One. Donc finalement, on se rend compte que un laser CO2, ce ne sont pas tous les mêmes. Il y a des particularités qu'il faut juste comprendre. Et justement, l'accompagnement est là pour vous montrer comment est-ce qu'on peut tirer le maximum de cette machine. Donc voilà, merci pour avoir assisté à cette deuxième session. Donc on va faire une petite pause maintenant, qui doit durer 10 minutes, 15 minutes maximum, parce qu'on a pris un peu de retard au début. Et on va attaquer la troisième session. Voilà.